everyone, in this episode I interview Professor Ian Bruce about lupus. If you enjoy these podcasts, please hit the like and subscribe buttons or visit iforgottooaskthedoctor.com. I'm Dr. Gail Busby and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor Ian Bruce about lupus. Ian is a consultant and professor of immunology. He specialises in lupus and vasculitis. He is a director of the National Institute of Health Research in the Manchester Biomedical Research Centre. He's a former chair of the Systemic Lupus International Collaborating Clinic Group, and he has a dedicated interest in personalised medicine in SLE. He is extensively published and regarded as an international expert. I'm absolutely honoured to have him on the show today. Ian, welcome. Thank you so much for agreeing to join me today.
Yeah, well, thanks very much for the very kind invitation.
So, Ian, I always find it really interesting to learn why high flyers and experts like yourself ended up in the branch of medicine in which they end up practicing. So can you enlighten us as to how you ended up working in the field of lupus?
So when I was a medical student, I was actually very inspired to do rheumatology, even as a fourth year medical student, mainly because it struck me that there was such a mystery about these illnesses. We didn't really fundamentally understand what was driving most of these conditions. So whenever I was doing my house officer year, I was able to spend 4 months in a rheumatology ward, and that really reinforced that that's what I wanted to do. I think the aspects of rheumatology that always have attracted me is that it's a chronic disease management specialty. So once you see your patient, they're with you for almost your entire career or often their entire lives. So for example, I've been in Manchester Royal Infirmary now 25 years, and some of the patients that I saw when I first arrived in 1998 are still coming to clinic, and you see them through their whole life course. So there's that aspect of chronic disease management. And then I think the other thing is the attraction of the sort of the understanding the immunology, understanding the process by which people get these multi-system diseases. So if you think about rheumatology, sometimes people have joints only, but these multi-system diseases can affect any part of your body. So therefore, there's a huge diagnostic challenge. And then there's also the management challenge of looking after multiple parts of the body at once. So you could treat the kidney, but what about the skin? You could treat the skin, but what about the joints? So I think that's been the fascinating thing. So chronic disease management, lifelong sort of management of patients, and then the immunology, the biology of the disease and the process of what drives these multi-system diseases.
So, Ian, as you know, this podcast is aimed at educating patients. So we try to avoid as far as possible medical terminology and jargon so that the podcast remains as accessible as possible to everyone. Okay?
Yeah.
So let's start with the basics. What exactly is lupus? Are there different types? Can you explain?
So lupus, some of your listeners might know this. Lupus comes from the word for wolf, and lupus describes probably the rash on the face, which looks like a wolf's features, if you like. And the full term is systemic lupus erythematosus. Essentially, if you think about illnesses in general, there are some illnesses where we get an infection, and we get pneumonia, we get an infection, we get a urinary tract infection. But there's some illnesses where your immune system, which is there to defend you against attack from the outside, essentially turns in on itself and it attacks your body's tissues. So lupus is that kind of condition. That's known as an autoimmune disease, where your immune system turns in on itself and basically you get damaged, if you like, by friendly fire. And autoimmune diseases can be single organ conditions. So somebody can have a thyroid disorder and that's all they've got is a thyroid that's affected, and that would be a single organ autoimmune disease. But lupus is in the multi-system autoimmune disease category. So it's your body attacking itself, and it can attack multiple tissues in your body. The common features of lupus include various kinds of skin rashes, joint pains and arthritis. Then you can get deep organ diseases we talk about. So that could be things like pleurisy or pericarditis, so inflammation on the lining of your heart or lungs. You can get kidney inflammation. Some people get brain involvement as well. So it can happen in multiple different places at the same time or sequentially. So as a result of that, there are also some people who look like they've got a single thing, like, for example, skin disease. And if that happens in isolation and stays in isolation, then we call that cutaneous lupus. So i.e. it's lupus of the skin that doesn't spread anywhere else. And in fact, many people with lupus in the skin, it doesn't spread anywhere else. So that's the way to think about it. You can subset. And then there's some people who get kidney disease, lupus nephritis. And often when you look at them, they don't have very much elsewhere. So it may be just the kidney only with some antibodies, but sometimes that doesn't spread elsewhere, but sometimes it can progress to other areas.
Okay. And so cutaneous lupus, is that the same as discoid lupus, or is that a separate entity as well?
So there's sort of three key types of skin lupus. There's the acute skin lupus. So somebody's out in the sunny day, they get a rash, typically in the sun-exposed areas, so their cheeks and their forehead. And that would be an acute cutaneous lupus, and that often settles down and goes away without leaving any marks. There's some people who get a thing called chronic or subacute cutaneous lupus. And again, that's often on the light exposed areas of the body. And it's different characteristics of rash, but again, that goes away and leaves no marks. And then the third type is discoid lupus. And discoid lupus is where you get inflammation in the skin, but you get a lot of thickening and scaling in the skin, and that can often cause damage to, let's say, the hair follicles or to the melanin layer in the skin, and therefore the skin can get scarring, and it can get increased pigmentation or reduced pigmentation. And if it happens on the scalp, it sometimes leaves a permanent bald patch on the scalp.
Thank you. That's really clear. So, so it's a multi-system disorder. So what symptoms are the most common presenting symptoms? So what can people look out for to think that they might have this or that? They think, well, I might have lupus. It might be worth going along to my GP, because some things you mentioned, like I guess lupus nephritis, it may not be obvious, kidney injury by the lupus, but skin things will be obvious. But are there any other kind of leading symptoms that you would think that you'd advise patients to look out for?
So some of the very early symptoms are what you would describe as very non-specific. So that's things like fatigue, aches and pains, so it's maybe slightly low mood, and those are very non-specific. They could be multiple conditions can present like that. And then there are things that are more suggestive. So things that would be more suggestive would be things like if you were to get bad circulation in your hands, which we call Raynaud's phenomenon, where you go out on a cold day, your hands go very pale and white, and then they go a bluish color. And then when you rewarm your hands, they go red and tingly. So that's called Raynaud's phenomenon. So that's a suggestive symptom. If you get things like photosensitive rashes, so there are lots of people who get prickly heat in a warm day, and they're sort of a bit itchy all over and things. But if you're getting specific rashes like over the bridge of your nose and onto your cheek, particularly if you can feel the rash as being a bit thickened, then that's a suggestive symptom. That coupled perhaps with, let's say, recurring mouth ulcers, and then swelling and stiffness of the joints. So if you've got some non-specific features and some of the more suggestive features, then it's worth going to speak to your GP. It's interesting, I think, that GPs have a very important role here, because we talk about the multi-system nature of lupus. It might be when they go back down through your notes, then they find that, oh, actually, this person had a clot in their leg 5 years ago, or maybe they had 3 miscarriages, or maybe they had pleurisy that was treated 2 or 3 times and they were given antibiotics, but nobody was ever convinced that they actually had an infection. And so the GP can pull a lot of that together and then maybe begin to say, well, let's think about whether this could be one of these multi-system illnesses. And then if it is, then think about getting referred for assessment and advice.
Okay. And that really underlines the importance of continuity of care, doesn't it? And the importance of GPs who are such an important resource, because, you know, they see patients over the course of their lives, and they can kind of sometimes connect the dots that different specialties may not connect.
Yes, absolutely. And if you think about the old idea in medicine of Occam's razor, which is, you know, if you get multiple things happening, sometimes there's a single explanation behind it all. Then lupus is a good example of an Occam's razor disease, where you've been to the respiratory physician, you've been to the obstetrician, you've been to the clotting specialist, you've been to the rheumatologist, and then somebody puts it all together. Aha, maybe this is actually lupus we're thinking about.
Absolutely. Okay, so are there any risk factors that are defined for developing lupus? Is it, for example, genetic or inherited? And I ask this question because the knock-on question, really, the question that lies behind that is there anything that people can do to help prevent developing lupus or even kind of delay it?
So we know that there's a very strong genetic tendency to lupus. In fact, we know that because there's some children who get lupus because they've got a single gene that's gone wrong,
Right.
and they get lupus from that. But in adults with lupus, we think there's up to about 150 different genes that can cluster together to increase your risk of SLE. And so there is a genetic susceptibility. We know that if someone has lupus, their family members are about 30 to 40 times more likely to get lupus than people in the general population. So that tells us it's a genetic component. Although, because it's so uncommon, the vast majority of offspring and siblings of someone with lupus won't get lupus. So that's to reassure as well.
Yeah.
But that tells us about genetics. Environmental risk factors, there are a number that have been looked at and a number have been identified. So there's been some really nice studies done in the United States where they've shown that types of silica exposure can drive lupus. So certain occupations where it's more prevalent. Cigarette smoking probably increases the risk of lupus. Because we know that it's way more common in women than men, there's been some evidence that the combined oral contraceptive pill can increase the risk of lupus a little bit. And then there are probably some dietary factors, but they've been very poorly defined. I mean, there's been some evidence, alfalfa sprouts exposure and things like that. But I think the main things are cigarette smoking, some hormonal exposures, and then probably some occupational exposures. When we think about silica, you think about people blasting in mines. But actually, there's been some studies where people who are working in the cleaning industry, because a lot of the scarring creams and stuff have got silica in them, that kind of exposure over a long period of time might be linked as well.
Okay, so that's really interesting. I didn't know that. Okay. And so suppose someone has a myriad of symptoms, or a few symptoms that you have suggested might be indicative, and they go along to their GP, as you've recommended. What can they expect? So sometimes a barrier to getting healthcare or getting diagnosed, I think, is not knowing what to expect, and maybe a certain anxiety or fear about what investigations are going to be performed. So I like to inform patients, as part of educating them, what tests they're likely to have, how their diagnosis is made, and what they can expect when they do attend to their GP.
So the diagnosis of lupus, similar to many rheumatic diseases, in fact, it goes back to the old, I think Osler said many years ago, to listen to the patient because they're telling you the diagnosis.
Absolutely.
And so actually taking a thorough history, and I say this to all junior doctors and GP trainees, I said, take a thorough history from the patient, everything in the past medical history could be of relevance. So a thorough history and examination, and maybe somebody's had a rash in their scalp before. If you find the little bald patches from previous scarring, that's a clue. Examining them thoroughly, dipsticking their urine to see whether there's any protein or blood in their urine is very important, because you don't feel that as a symptom.
Yeah.
And then the rest of it is, the next step is usually blood tests. And so things like your blood count, your kidney function, your liver function, levels of inflammation. And then we do a panel of autoantibodies. So autoantibodies are very important, because if you think about what I said earlier, that this is an autoimmune disease, your immune system declares itself as being part of the problem if you've got a series of antibodies to yourself that are positive in your blood. So the typical ones is one called the anti-nuclear antibody. And then one of the other typical ones is called anti-double-stranded DNA. So all our cells have double-stranded DNA in them, and some people generate antibodies to double-stranded DNA. So the anti-nuclear antibodies to double-stranded DNA are two of the cardinal ones. There's others as well, but those are the sort of key ones. So if you go to a GP or come to a rheumatologist, the first thing they'll do is a thorough history, do a panel of blood tests, and then if there's any suggestion of a particular organ being affected, then they would probably go into more depth, either with scanning or imaging. Kidney, we would often get a kidney biopsy from a nephrologist to do that for us.
Okay. So nothing too scary for a kickoff.
No.
To get the first indications, and then referral onward as necessary. Yeah? Okay, perfect. Yeah. And it is a multisystem disorder, and you have mentioned many organ systems and organs that are potentially affected by lupus, not all in the same person. Can you give us an idea of what the long-term effects of lupus might be? The natural history of disease, meaning what happens with the disease and what can people expect? And I understand, obviously it's variable, it's obvious from what you've said before, but just to give people an idea.
Yeah, so broadly speaking, lupus presents with a series of symptoms and signs, and it runs what we describe as a relapsing and remitting course. So it is a chronic illness. There's no cure for it, so there's nothing you can give and say that'll go away and it's never going to come back. So it's but it is a manageable condition. Yep. And we broadly think about it as being mild, moderate, or severe. So some people who've got very mild disease, they might just have a rash and nothing else. They might have some skin and joint involvement, and some of their blood tests are a little bit abnormal, but it never progresses beyond that. Then there are people who would describe as having moderate disease. So that might be like pleurisy, inflammation in your lung, inflammation around the surface of your heart, that kind of thing. And that would be in the moderate end. The more severe end of the spectrum tends to be people who've got I think about it in several ways. So if you've got brain or nervous system involvement, I would classify that as severe. If you've got kidney involvement, or if you've got lots of things happening at once. So we often see people who come in who've got fevers, who their lymph glands are enlarged, their blood counts are really low, they're just really unwell. So I think those would be the three groups that would be in the more severe end of the spectrum. But as I say, the majority of people are in the mild or the mild to moderate category, and the severe end of the spectrum is less common. But if you think about the long-term prognosis, the severity does guide you when we think about long-term prognosis.
Okay. And if someone has the symptoms that we've discussed before, and they're thinking of going along to their GP, would you recommend that they go sooner rather than later? And what I'm asking here is, does earlier diagnosis or earlier treatment affect outcomes or the long-term course of the disease?
So I think I would say yes, it does, and for several reasons. First of all, it's for the patient's well-being. The shorter the time between developing any symptom and getting a diagnosis is better, because we did a survey in the UK about 7 or 8 years ago, And we found that the average time between patients describing their first symptom and getting a diagnosis was something between 6 and 7 years, right? So over that 6 or 7 years, they're told all sorts of things. They're told they've got all sorts of things. They've got viral illnesses, they get post-viral fatigue, they've got some psychological issues or depression. And that actually is quite debilitating for patients to sort of live with that uncertainty for a long time. So I think early diagnosis helps that. Secondly, I think that if we see people early, even if they're in the mild to moderate category, if there's some things that worry us a little bit, we're quite vigilant in certain categories of patients to make sure we screen for kidney disease all the time. We look for early indicators of the more severe involvement, so we have a lower threshold to investigate them. And then that means that we can get that earlier before it becomes very severe. We've seen patients in the past, for example, who've come for the first time and they've got kidney failure, and actually it's occurred maybe grumbling in, for, it's building up over a period of time. Whereas maybe if they had been seen earlier when they were at the rash and joint pain stage, somebody would have dipped their urine, said, you've got kidney disease, treat it, and then alter the natural course of the disease.
Okay. So I guess what we don't want to do is overwhelm primary care with people who have a bit of fatigue. But certainly if you have a couple of these symptoms, and particularly the joint pain you keep repeating and the rash, those are quite indicative, then go along sooner rather than later.
Yeah.
Would you agree with that statement?
So I think it's that combination. So you say, if you say, you go to your GP, if you think about it from a GP perspective, if you think about the prevalence of lupus. So lupus probably occurs in between 50 and 100 per 100,000 people in the UK. So it's uncommon.
Yeah.
It's not excessively rare, but it's uncommon.
Yeah.
If every GP has, let's say, 2,000 people in their practice, they'll probably see, they might only have one patient with lupus in their entire practice, and they might diagnose one every 5-10 years. So therefore, you think every day of the week they're seeing 30, 40 people, many of whom have got fatigue and aches and pains and low mood.
Yeah.
The vast majority of that is something else. But if you've that coupled with some of these more suggestive features, as we talked about earlier, then the more of those you have, the more you think about, well, this sounds like it's more than just garden variety, fatigue, whatever that is. So I think it's that combination. It's all about that combination and past medical history, etc.
Yeah. Okay, and moving on to, so we know the symptoms to look out for, we know what the risk factors are, we know how quickly you should go along to your GP and the things that should inspire you to go. We know what the course of disease is likely to be like, roughly. Let's talk about treatment. So what are the treatment options for lupus?
So we're in a very exciting phase at the minute, actually, because we're beginning to develop some new treatments for lupus. But we also know how to use our old drugs better. I think that's the other big thing we've learned. Okay. So the cornerstone, there are several lifestyle things that we ask people to do if they develop lupus. So avoiding direct sunshine. Also, if you're photosensitive, some people who are photosensitive are photosensitive obviously in the sunshine, but some people also get it under low energy light bulbs. So we have some people who get a rash with low energy light bulbs because it's the same, there may be that UV spectrum that's sort of triggering it with them. So you want to think about all of that. Stopping smoking is really important. Healthy lifestyle, good diet and exercise is all very important because that helps with your well-being. It probably is good for your immune system. And we do know that smokers have worse outcomes from many of the things that we do or we see in lupus. One of the cornerstone early drugs that we use is actually an anti-malarial drug called hydroxychloroquine. And this was very probably serendipitously noted to be beneficial. There were some very old stories in the late 1800s about the use of anti-malarials, but certainly during the war years when lots of soldiers were sent off to the Far East and given anti-malarials to prevent them getting malaria. Some of them with arthritis and lupus rashes felt better. And so hydroxychloroquine has become a mainstay drug. In fact, it's one of those things where we recommend, all the guidelines say, unless there's a strong reason why you can't have it, you should be on hydroxychloroquine. And it's very effective for skin disease. It's very effective for joints. It's very effective for those constitutional symptoms like tiredness and aching and stuff like that. One of the drugs we used to use all the time from very early on were steroids. And we'll talk maybe a bit more about steroids later, but steroids have lots of long-term side effects that we worry about. But they are a drug that will instantly make people feel better within a very short period of time of starting steroids. The rash will go away, the joint pains will go away. If their blood counts are low, they'll come back up, etc. And then we have another range of drugs that we use, which we call immunosuppressives or disease-modifying drugs. And those are things like methotrexate, azathioprine, there's a drug called mycophenolate mofetil. Those are kind of drugs that we use as well. They're often for the moderate to severe end of the spectrum. And then we've got some new biological drugs, so specifically targeted therapies against some of the molecules that drive lupus. So we've got one that we use that's approved called rituximab. We've one called belimumab, which is also approved for use. There's one called anifrolumab, which isn't available in the UK yet, but is available in the United States and parts of Europe. And it targets one of the key parts of the immune system that go wrong in lupus. And those have all been effective in clinical trials and clinical studies.
Okay, well, that sounds really exciting. And those drugs, that family of drugs, come up again and again in my podcasts, so, they're exciting a lot of specialists, actually.
They are indeed. And I think it's because I think you can target. So if you think about coming back to the steroids is like almost like a bit of a blunderbuss. It hits multiple parts of your immune system. Whereas these drugs are much more targeted onto a single pathway that we think is very important in lupus.
Fantastic. Okay. And can you give us an idea of how successful treatment is in improving the lives and diminishing symptoms in patients with lupus? And also, are there any factors that affect how effective treatment is? So is there anything that patients can do to improve their treatment outcomes, apart from giving up smoking, like you said? You've said all those lifestyle things. Anything else?
So coming back to the smoking, smoking is important because we do know that people who take an antimalarial drug, the antimalarial drug works less well if you continue to smoke. So we encourage, because it deactivates, the smoking stimulates enzymes that deactivate the hydroxychloroquine. So they kind of go hand in hand. If you look overall, the majority of people improve with the treatments that we give them, and they stabilize their disease. But if you think about one of the words that we talk about in other branches of medicine, like remission, getting people into a remission, it's actually with the current drugs we've got, you don't get as high a percentage into a full, complete remission as we would like. So I did a study when I worked in Canada in a lupus center in Canada about 25 years ago. And we did this study where we took everybody in the Toronto lupus cohort, there's over 2,000 of them, and we said, how many of them came off all their treatment for more than 5 years in complete remission? And it turns out there was less than 2% that was feasible for. But if you then add in how many people were very well and very stable on some moderate background therapy, recent studies have shown that up to 50%, 50-60% will be in that kind of state at any given time. So that's much more reassuring. So if people say to me, am I going to be able to get off all my drugs for a very long period of time? We'd say, probably not. But can we control the disease and make it manageable and get you back to work and back as a functioning member of society and a functioning member of your family, etc.? For the majority of people, we can do that. We need to do better because we know that some of these drugs, even in clinical trials, some of these new drugs, they get a proportion of people really, really well. And for some people, they just don't work because that's not the target. That's not the pathway that's affecting their disease most. And so we need to do better. And that's part of that you said earlier about the sort of personalized medicine piece. I think we need to learn more about that. From a patient perspective, I think there's one of the key things I would say to patients is that we know now that a lot of patients don't take their drugs even when they're prescribed as regularly as they should. And we know this because, for example, I have a colleague in Paris who's developed this blood test where you can measure the amount of hydroxychloroquine in your circulation. Right. And people who are on hydroxychloroquine, it turns out that about 15%, so 1 in 8, you can't detect it in their bloodstream at all because they're actually not taking it regularly. And so adherence, we call it concordance is probably a better word, because adherence means you're adhering to my, it feels that there's a power dynamic there. Concordance is that the patient agrees, the doctor and the patient agree that this is what we should be doing. So we have a concordance. And I think that means that doctors and nurses need to educate and support patients better in taking their medications. And I think actually, if patients decide they don't want to take medications, I try to encourage a very open and honest policy with my patients. And if they're not taking their drugs, just tell me, it's fine. I'll not be angry. Yeah. I'm not going to wag my finger at you, but I need to know, because if you escalate to the next level and the next level, that could cause more harm. So we spend a lot of time quizzing people about whether they're taking the drugs or not. And if they're not, we try and encourage them, because there's often a reason, there's a concern or a worry that people have, and we try and sort of help educate and support them through that. Particularly when you think about it, that lupus, and we might come on to this later, lupus is often a disease that affects women in their childbearing years. And so while I'm sitting encouraging them to take these treatments, some of those treatments are not compatible with pregnancy because they cause harm to the baby, or they may be worried that it's going to affect their fertility. So therefore, we need to understand that. Where are you in your life course? What's your plan over the next few years? So we can give you something that works and is compatible with your plans over the next couple of years, rather than hoping that they're going to take it and hoping that they do take it, you know.
And that's actually part of my inspiration for doing this series of podcasts, because we can reach patients who, you know, we may not have direct contact, but they may have an unanswered question. And if we can answer that question, then, you know, it's just helpful to them. So thank you for your really clear answers.
Absolutely, yeah.
So the next question is about staying on treatment. What are the, and I know because there are several treatments you have listed, so I know the answer to this is broad. My next question is, are there any risks or side effects of treatment? And of course there will be many, but are there any that you think are prominent or significant enough to warrant special mention today?
Yeah, so with the hydroxychloroquine, I would be assuring many people who have got lupus and are on this, watching this podcast, I would assure them that hydroxychloroquine overall is a very, very safe drug. There are occasionally people who get nausea with it. They stay on the drug for 5-10 years. It can build up at the back of the eye, and some of that side effect may be irreversible. So therefore, there's a monitoring regime we now have for hydroxychloroquine that we track people, and we ask the eye team to follow them and look for early signs of that side effect and then modify treatment if we need to. But overall, I would say hydroxychloroquine is a very, very safe and very acceptable drug. Steroids, everybody knows about steroids. We have a love-hate relationship with them. Many patients say they can't live with them and they can't live without them. And the key things about steroids are weight gain. They can put your blood pressure up. They can make you more of a tendency towards diabetes. And then also bone thinning, so osteoporosis. And we would monitor people for those, and we'd ask people to monitor those things themselves. One of the big things about steroids I keep saying to patients is they fool you into thinking that you haven't eaten enough. So you sit down at your dinner table, you eat your dinner, and you think, I could do with another plate of that. And so it fools you into thinking that you need to eat more. And I must say that one of the big things that we've been doing over the last number of years in lupus is to try and minimize the amount of steroids that people take by using some of these other drugs. If you then think about steroids plus all those other drugs, broadly speaking, I would say most of those other drugs, methotrexate, azathioprine, mycophenolate, we can monitor the blood counts, we can monitor the blood tests, and that helps us get an early warning of side effects. And overall, as a group, because they suppress your immune system, infection is an issue. And so therefore, we ask people to be vigilant about infection, be very, try a low threshold for getting treatment for any potential infection. And then we try and modify the treatment if infection is a recurring problem.
Okay. So thank you for those very clear and detailed answers to my questions. And I just have to comment that of all the podcasts I've done, I think this one takes me back the most to being in medical school. Because I don't know if SLE is more common in the Caribbean or people of the Caribbean, but we had quite a few patients, women with SLE. And I remember learning all those criteria and learning all the side effects of steroids. So,
well, it's one thing I forgot to say, actually, and I neglected to say it earlier, is that you're absolutely right. There is a very large ethnic gradient with lupus. So if you look at, I think, I spoke to the rheumatologist in Barbados once, and she said to me that they had over 120 people with lupus in Barbados that she knew of, and that's an island of 100,000 people. Yeah. So that is much more than you would expect in a sample of 100,000 white people in Manchester. Yeah. And we did a study, in my colleague Mumtaz Patel, who's a kidney specialist, she and I did a study about 15 years ago, and we looked at kidney disease in lupus. And if you take people from Black backgrounds and Chinese backgrounds, they're 20 times more likely to have kidney disease linked to lupus than white British patients. So that means that, again, when we think about management of lupus, if we have someone coming who's African or Afro-Caribbean or of any African ancestry, we're always thinking, let's make sure you dipstick the urine, make sure you look for kidney disease, etc., and a very low threshold. Absolutely. And of course, it comes to maybe another thing which we're doing some research on at the minute is the global health issue that lupus is. Because if you think about it, a lot of those new drugs I'm telling you about are very expensive, and they're less affordable in the parts of the world where lupus is more severe.
Well, hopefully in the fullness of time.
And so we've actually got we've actually got a research fellow who's going to be doing some work in Kenya over the next 3 years to look at this in more depth, because I think what we need to do is develop evidence that we can influence policy to give people who've got more severe disease access to the treatments that actually work.
Okay, perfect. So, thank you again. As you know, Ian, I ask patients, listeners, before the podcast to send in questions to ask the expert. Are you happy that I ask those questions to you now?
Yes, happy to try my best, yeah.
So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these questions should only be used as a guide, and individualized care should be sought from one's own doctor. Okay, so our first question. Hi, could I ask if lupus and libido could be covered in your podcast? Many thanks. It's something I've never had the guts to ask my rheumatologist. And therein lies the beauty of doing this podcast. So this person can now ask you a question that they've maybe had lupus for many years and have always wondered this. So please put them out of their misery. What is the relationship between lupus and libido?
First of all, I think it's good that someone's brave enough to ask a question like that, even anonymously. I think that's really important because it shines a light on something I think very important. So libido and sexual function, I think, are quite significantly impaired by lupus. So a colleague of ours did a questionnaire, developed a brand new questionnaire for lupus and the quality of life about 15 years ago. And one of the areas that patients told us was important, which was not measured anywhere else, was body image. So what I've described to you earlier is, you can imagine if someone has rashes that they're embarrassed about, or hair loss, or weight gain from their steroids, or if they've got recurring ulcers, which can occur vaginally as well as orally. All of those things can affect body image and libido. Also, the fatigue that patients get is often quite overwhelming. And one of the things that lupus patients always say is that sometimes family members, sometimes friends, etc., will say, well, you look fine to me. And yet they feel terrible. So fatigue can affect libido. Body image can affect libido. The dryness, so a lot of our patients also get Sjogren's syndrome overlapping with their lupus. So they get oral dryness, they get dryness of their eyes, but they also can get vaginal dryness as well. And then think if you've got arthritis or muscle dysfunction, then of course that can obviously be an impairment as well, and chronic pain. So I think there's multiple reasons why libido can be affected. It's probably not been as well studied as it should, but thank you for someone asking that question, because I think it's important to say there are multiple factors that could drive that.
Thank you for your answer. Okay, the next question is, I have discoid lupus, which I started with patchy hair loss sometime after a Marina coil was fitted. And a Marina coil is a contraceptive coil that contains the female hormone progesterone, or a synthetic version of it. I had an inconclusive biopsy of my scalp. I took the coil out and it helped a bit. I was put on hydroxychloroquine and Dermavate, which is a steroid ointment, which helped the hair loss. I was worried about vision side effects of the tablets and stopped them. So exactly what you've said. My hair loss has settled until recently, when it has started again. Can I just use the ointment, or do I need to restart hydroxychloroquine? Should I get another biopsy?
So if someone's been treated, settles down, it flares again. If it's flaring again, then it's always worth getting another look at that, because you want to see if there's any redness and scaling. Is there typical features of discoid lupus in the scalp? A dermatologist might be able to confirm that that's what it is without doing a further biopsy, because you can imagine a scalp biopsy can be quite painful because the skin's very tight, etc., etc. Topical treatments like Dermavate are very useful for discoid lesions, and sometimes you have to use an even stronger topical steroid. It's one of the few reasons why you would use a much stronger topical steroid. So it is worth consulting a dermatologist for advice on the type of topical steroid. Sometimes they also inject the lesion with a little bit of steroid just in under the skin. And then if that settled it down, that would be fine. But if not, then restarting the hydroxychloroquine would probably help to settle things and prevent it coming back again.
Perfect. So again, the Marina coil is featuring. I've had a Marina coil for 2 years and have started getting a rash over my cheeks. My dermatologist suggested that it may be due to the hormones, but the rash looks like a lupus rash when I Googled it. Can the Marina coil spark off lupus?
So I actually had to look this up and think about it, because of course the Marina coil does have a small amount of progesterone. As far as I understand, there's very little of it gets into the general circulation. It's actually the estrogen containing pills that seem to be a risk factor for lupus rather than the Marina coil. So I would say they're probably two separate things. You've got a Marina coil in for your contraception, you've developed a rash. It's not going to be the Marina coil causing the rash. So therefore, what I would suggest is you get the rash looked at as a standalone thing. And if it looks like a lupus rash, it's probably worth asking that question and getting somebody to look at it and confirm or refute it, because there's some things that look a bit like lupus, acne rosacea and things like that. But again, there's a differential diagnosis and it's worth just looking into that.
Okay. Yes. And again, to be fair, you agree with the dermatologist, because the dermatologist didn't seem to think it was a lupus rash. So that clears that up.
Yeah.
The next question is, hi, Dr. Gail. I will be 30 in a few months and I want to start planning a family. Please, can you ask what effect lupus will have on pregnancy? And will I need to do anything extra, or should I be doing anything now because of my lupus?
Right. Okay. So you might know, Gail, that myself and Professor Claire Tower do a combined
Yeah.
clinic where we look after women with lupus in pregnancy. And it's specifically for that reason. There's lots of things to think about, particularly what type of lupus you have, what organ systems have been involved, and then how active the lupus is at this point in time. So our general rule is if your lupus is quiescent for 6 months or more before you try to conceive, that's a good place to start. The second thing then is, what about the drugs you're on? So there's some drugs that are fine for you to get pregnant with, so hydroxychloroquine, steroids, azathioprine, things like that. There are certain drugs that we would want to stop and change before you get pregnant. So mycophenolate mofetil is a good case in point. And of course, if you change a treatment in preparation for pregnancy, you want to make sure that you don't then have a flare when you change your treatment. So that's why we would then spend a good 6 months switching the treatment and saying, on the switch of treatment, you haven't flared, that's absolutely fine. So those are the things to consider. So plan ahead is the watchword there. And then when you're pregnant, you'll find that people will follow you very carefully. They'll want to see whether there's any flare up of your lupus. But then obviously in the second half of pregnancy, one of the things that people often get is a thing called preeclampsia, which is sort of a combination of high blood pressure, protein in your urine, and swelling. And you could say, well, that looks like a lupus flare. It sounds like a lupus flare you're describing. And so actually tracking people carefully during the pregnancy so you can begin to try and work out if they're moving in a trend towards blood pressure going up, etc. Does this look more like preeclampsia, for which the management is early delivery, or is this a lupus flare, in which case you might have to make some tough decisions during the pregnancy about treatment? And just to say that if you have a lupus flare in pregnancy, we don't then say, oh, we have to terminate the pregnancy. We can treat the pregnancy. We can often treat lupus in pregnancy successfully to get you to the point where you can be delivered. So I think that's the thing in the preeclampsia. Disentangling preeclampsia from a lupus flare is often quite tricky, but part of that is about tracking them carefully in the pregnancy so that you can see where the trend starts.
Okay. So, so basically, if you have lupus, don't just get pregnant. Think about it before. Have perhaps preconceptual counselling, and that's when people with chronic disease will see someone like yourself or an obstetrician before they even try for pregnancy to optimize their general condition in preparation for pregnancy, and then close management by a highly specialized team such as yourself and Professor Tower.
Yes.
Yeah.
And then I think you'll know this, Gail, as well, is that the clotting risk during pregnancy goes up anyway. And every pregnant woman has a clotting risk calculated. Lupus, if it's active, if you get sticky blood markers, that kind of thing, that might put you into the territory where we would actually give you drugs to thin your blood as well during the pregnancy. So we think about that.
So a lot to consider. Yeah, good question.
Yes.
Okay. Hi, Gail. Can you ask him about seizures? My sister-in-law is having 5 a day.
Right, so seizures are more common in lupus. So epilepsy is one of the cardinal features of lupus. It's rare, but we see it a lot. And then some people with lupus who, let's say, have had a stroke where they get a little bit of scarring in their brain, that can drive seizures as well. So it's probably worth getting them investigated thoroughly as to, is there any other underlying cause? Because sometimes there's other structural brain problems that can drive epilepsy. And then the management is often with standard anticonvulsants. And then depending on the type of seizure and the distribution of the seizures, they choose, and then a neurologist would choose the right medication to settle the seizures down. But yes, it can be linked with lupus.
Okay, so that person probably needs to go along and be reevaluated, reassessed, and maybe consider changing the dose or the medication they're on.
Yes.
And rule out other causes. Thank you. So go along to see the doctor. Okay, what living support or grants are available? Occupational therapies won't budge on many things.
So occupational therapists I do find very helpful, particularly for things like if you've got joint pains or difficulty with gripping or things like that. There's a lot of aids and appliances you can get to help if you've got lots of musculoskeletal symptoms that are causing limitations. So I would try and find a friendly occupational therapist to help. There'll be no specific grants for lupus, so most of the grants would be around assisted living, which would be from the general sort of department of sort of the government departments. So there'll be certain people would qualify for different grants based on that, but there's none specific for lupus as such.
Okay. And the next question is a long one, but I think really important. What are the links between weight gain, pain medication, and lupus? Many pain meds cause weight gain and water retention, but many GPs and doctors will not advise about this. Over the years of being on high doses of steroids and pain medication because the wrong diagnosis was made, I have nearly doubled in weight. I have stopped all but my azathioprine because of this. I have slowly started to lose weight again. Many times I wanted to just give up and hope for a heart attack to end my life, because you have doctors who look at us as a fat person and are adamant you do nothing all day but eat. I have tried many diets. Some days I can't move much because of the pain, and pain meds never helped much. I would love for cannabis to be allowed as medication for chronic pain, but this is only available as a private prescription. My last appointment was the same. Go walking, go for a jog, go to the gym, go swimming. I can't be in the sun for long. I'm on medication to suppress my immune system. I have back problems too. I was assaulted many years ago in the street. They now tell me it's because of my weight gain. I had been crying for help when I was at a BMI of 31. I am now at a BMI of 46. This is why I have stopped meds that cause weight gain. I hope this can help you to get the point across to many to understand. It's not just a battle against your conditions, it is also a battle against doctors who discriminate. So I think that encapsulated really powerfully many issues that patients, I guess, with lupus face and many other chronic diseases face.
Yes, I suppose so maybe I could just comment on a couple of aspects in that just from a general perspective. So one thing is that we have a tertiary referral service, and the two of the common things that we're asked about in the tertiary referral center, one is if people have got severe disease and need to escalate their treatment, what's the next step up? But often we find that there are people who have a lot of the symptoms are not primarily due to lupus, but they're erroneously attributed to be lupus, and the answer then is put your steroids up or stay on those doses of steroids. And exactly as the patient describes, and as exactly as we've discussed earlier, steroids do drive weight gain. And that then means you're in this kind of loop where you're getting more aches and pains, they're attributed to lupus, keep taking the steroids, you put them on more weight. So we often spend time actually trying to sort of reverse that trend and sort of get people back down. And sometimes that's about making alternative diagnoses and say, well, actually, maybe that aspect is due to osteoarthritis or fibromyalgia or something else, and then manage those things and try and get steroids down and try to educate both the GP and the patient about what's the lupus symptoms and what's your non-lupus symptoms. So that's a big chunk of that, I think. I also think my general observation about pain medication, and I think this is borne out a lot by a lot of studies recently, is that there's a tendency to put people onto pain medication, and if they don't work, you either add something else or escalate the dose, as opposed to saying, is this actually going to work at all? If it doesn't work, stop it and try something else, but don't add and add and add, because we often see people who come in with 3 or 4 different pain meds, makes them very drowsy, can promote weight gain and fluid retention, as the patient says, but it's not actually helping the primary problem. So therefore you end up with very drowsy, can't do any exercise because you're so sleepy. So you hit another vicious cycle. So it's breaking some of these cycles, and that's a really difficult thing to do. But I think, again, it's about seeing people, understanding what's happening, giving clear explanations as to what you think is happening, and then sort of going from there.
And really individualized care, I guess, is really important.
I think so, yes.
Okay.
Yeah.
Okay, the next question. What's my life going to look like with lupus? And I guess we've been talking about that for the past hour. I don't know if there's anything you want to add to that.
Yeah. So I would be very positive if someone has a diagnosis with lupus. It's a manageable condition. There are new treatments and current treatments that we use well, which often manage the condition extremely well. And we've people who are back at work and living sort of a full life in society, and they can have children, they can have a family life, etc. So I would be generally positive, and I would encourage people to think positively about that, and also to do some of the lifestyle things, because that gives you some control over your own life. So I think keeping some control, and then taking action to sort of adhere to medications. But I'm very positive about lupus in general.
That's a great answer. That's what we like to hear. So the next question is, would Humira help me? I take these shots and they keep me moving with some pain. I still have pain, but it's tolerable.
So Humira, for your listeners, is a drug which is the active ingredient is called adalimumab, and adalimumab is one of these biologics we talked about earlier. It's interesting because adalimumab is a biologic that tackles or blocks a protein called TNF, so it's known as an anti-TNF drug. Now, anti-TNF drugs we tend not to use for lupus primarily, because there are actually some people who are on an anti-TNF drug where you can actually trigger lupus because of the balance of these various different proteins. But there are some people who are on Humira for, like, let's say, a lupus arthritis. And that might be because the predominant thing they have is more like a rheumatoid arthritis type pattern, and they might have some features of lupus. And the doctor has decided the Humira works well for the rheumatoid arthritis aspect, and the rest of the mild lupus features are not going to be affected by this, so that's okay to do. But so Humira might work well for a small number, but I think if you looked in our lupus clinic, there's maybe 1 or 2 patients on an anti-TNF drug. Most they're on these other ones which target B cells, which are more central to the pathogenesis or the development of lupus.
That's interesting. Okay, the next question. What can someone living with lupus do to avoid taking prescription pain medication?
So I think, first of all, if the pain is driven by inflammation caused by the lupus, then using other treatments to control the pain, anti-inflammatories, so things like the drugs we talked about, azathioprine, methotrexate, and that. So controlling it that way. And then if it's more sort of maybe chronic, what we call chronic widespread pain, fibromyalgia type of symptoms, again, I don't think that chronic pain medications work particularly well in that particular condition. And I do think that things like more mindfulness techniques, physical exercise, strengthening exercise often help much better. In fact, a colleague of mine in Scotland did a study recently in people who had lots of chronic fatigue linked to rheumatological conditions. And they found that exercise helped a lot, partly because it helped with your exercise tolerance, but there was that added well-being of doing exercise that helped. And of course, many people really struggle to start with exercise because of some people get this post-exertional malaise and things like that. I think there's a role to try and build up what you do, and not be put off by a little bit of a setback, but sort of to try and keep going. So I think those kind of things are often useful, and I think the mindfulness techniques and things you can get tapes and probably podcasts, rival
Hey.
podcasts, which you can listen to, and I think that often helps as well with things like pain and relaxation and things like that.
And like you say, the whole concept of taking control and you doing something is really empowering, isn't it? Generally speaking.
Yeah, yeah.
Okay. Okay. Since each person with lupus is unique, is there anything patients can do to improve our health and wellness? And again, I guess what you've just said and reiterated before.
Yeah, I think that many of the things we've talked about already about lifestyle, healthy lifestyles, and a positive attitude. There was a study, it was a colleague of mine in the States did a study a number of years ago, and one of the most powerful predictors of long-term outcomes in lupus was what he described as your locus of control. And people who have an internal locus of control, I can influence what
Yeah.
I do, and I want to have some control over my life. They had a better outcome than people who had an external locus of control. It's all about the ether. It's all about punishment or
Yes.
whatever, and that psychological construct is important, and also your views. Some people think about the immediate here and now, and other people are more future focused. And people who are future focused tend to have a better long term outcome than people who are focused in the here and now. And so I think thinking about that and sort of thinking about planning for your future over the next few years, I am going to try and get off my steroids. I'm going to try and lose weight. I'm going to try and do more exercise. Thinking in the long term is really important. And then having that locus of control. I am in control of this to a certain extent.
Okay. Okay. And this is similar to what you've just been saying. How important do you feel treating a lupus patient's mental health issues and physical symptoms correlate? So exactly
Exactly
what
as
you
we've
were just saying.
described. I think it's holistic, and I think it's meant to be a holistic management plan, because it's not that your mental health and your physical health are two separate things. We're all
Yeah.
one holistic being, and I think that positive attitude, listening to people, empowering them, is all part of physical and mental health.
Okay. The next question, again, you've mentioned this just at the start of the interview. What would you tell someone who, after years of symptoms and pain, who is newly diagnosed? By the time I was officially diagnosed, I was frustrated and angry with healthcare providers. Do you see this quite frequently?
We do, and we see that delay, and I think that questionnaire I mentioned as well, that we did suggest that this is quite
Yeah.
common. I think that one of the things is that if you can make a clear diagnosis and say, this is lupus, and we can do something about it, that is really important, because that means people think that maybe I'm at the end of my journey here, and I'm on the path now to
Exactly.
recovery. But I think also you have to bear in mind that means you have to build trust,
Yeah.
because they've seen numerous other people and numerous other bits of the healthcare system, and probably their trust in the overall healthcare system isn't as high as it ought to be. So one has to spend a bit of time building trust then.
What can a lupus patient do to help explain and raise lupus awareness among family, friends, and community? Listen to my podcast, obviously.
Well, there's a very good podcast coming out, so you can listen to that and promote that amongst your friends. And also Lupus UK, which is the national charity for lupus, they're very good. They've got regional branches. So there's a Northwest branch, there's a group in the north of east of England and Scotland and Northern Ireland, etc. So I think join Lupus UK. Lupus UK have some fantastic publicity material. There's Lupus Awareness Month is in October this year. So they would love to hear from any of our lupus patients listening. Join up, take part in your local group, and they will have lots of awareness events, and would love to sort of find novel ways to raise awareness, because you're right, it's one of those kind of I mean, I meet people socially and they say, what's your specialty? And I say, well, look after lupus. And they go, I think I've heard of that. And it's just it's in that territory of people think they've heard of it. But it's not something you go, oh, yes, I know all about lupus. Whereas if you say leukemia or if you say multiple sclerosis, people know what that is. So it's in that kind. So more awareness is important. But join the society, join Lupus UK and promote this podcast. And I think you'll do something for Lupus Awareness Month.
And I will put links to Lupus UK in the podcast notes, show notes, so that people can click through easily.
Yeah, thank you. Thank you.
Okay, and the last question from our listeners: what can lupus patients do to help researchers improve treatment? How can lupus patients support clinical trials? That's a really important question as well.
So, yes, absolutely. So, there are probably two key ways. Is first of all to ask your doctor that you see, are they involved in lupus clinical trials? Is their department involved in clinical trials? And if not, where's the nearest centre that's involved in clinical trials? So if there are clinical trials in your region and you're willing to come along, feel free. We would see you, we'd assess you, and you'll see if there was a trial that would be suitable. The second thing I think that patients can do is they can get involved in the sort of the patient and public involvement part of research. So, for example, in our Biomedical Research Centre, we have a large patient and public involvement group called Vocal, and they kind of coordinate our patient and public involvement engagement. And so we often start a new study, and as researchers, we think we want to do this and this and this and this, and we're going to ask that question, that question, that question, and all these, and you end up with sort of 10 pages of questions, and you've got sort of multiple things you want to do to the patient. What we do is we often engage with patients when we're designing the study, and they've often said to us, look, that's far too much to ask anybody to do at one time. Pare that down. It makes it more acceptable. It makes the study more successful because more people will stick with it, etc. So ask, is there a way to get involved in patient and public involvement in research? And most research centres will be looking for patient groups to help advise them in studies and what's the relevant research question. I mean, we've got a researcher in Manchester now doing a lot of work on cognitive impairment and brain fog, because that's a real issue for many of our patients. And she's done some really nice work and she wants to continue that. So that was driven by patients saying this is a really pervasive symptom and we want to know what we can do about it. So they suggest questions to us, and that's really important.
Perfect. Okay, so the last question comes from me. Ian, you have managed many, many patients with lupus in your career thus far. Given the opportunity, is there anything you'd like to say to patients who think they may have lupus or have been diagnosed with lupus?
So I think when I was a medical student, our professor of bacteriology said to us, how do you manage listeriosis? He said, the first thing you do is think of it. Because if you don't think of it, you'll never diagnose it. And if a patient thinks they might have lupus, it costs nothing to ask the question. And if you get reassurance, no, we've done some tests, we've looked at your history, this is not lupus. That's a good outcome. So if you think of it, ask the question, costs nothing. I think if you are diagnosed with lupus, there are bits of the internet where you can read and you just think this is an awful condition, my life's over. But I can reassure you that we have a large number of our lupus patients who are in employment, who are living a full life, who have got back to their normal routine, whatever that job or if they're at home or whatever, and they're living a full life. So I think we can be very positive about it. And it's not a life sentence, if you like, but it is something that we have to manage with you to sort of keep you sort of doing well and continue to do well. And I think there's some really good treatments now So I'm quite optimistic. But I think if you think about it, ask the question, and if you're diagnosed, don't think that your life's over. There's lots and lots we can do now, and we can manage people extremely well.
That's fantastic. Thank you. So, in closing, Ian, just remains for me to thank you so much for joining me today. I've had a wonderful time during this interview and I've learned a lot. Thank you so much for supporting my efforts to educate patients. And most of all, thank you so much for your work and your ongoing work in your distinguished career, which has really helped patients with lupus, and you continue to do so. And thank you as well for giving us such a positive outlook for patients who have been diagnosed with lupus. The future seems really bright to me. Thank you so much.
Well, thank you for this opportunity, Gail. I enjoyed that, and I hope it helps some people.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.